Hello everyone, and thank you for joining us for today's webinar with Mingle Analytics. Our topic is diving into the 2018 proposed rule, as well as what that tells you about the future of MIPS, with CEO Dr. Dan Mingle. Before we get started, I just want to remind you all that our website is chock full of resources to help you understand MIPS and the new quality payment program. We have recorded webinars on demand, ebooks, guides, a whole set of resources. So we do invite you to make use of that. Our next webinar will be next week on August 29th at 12 p.m. Eastern. We'll be revisiting our webinar, Getting Started with MIPS, a concise overview of the program, and introducing you to MIPS Solutions, our suite of quality reporting services that help you successfully submit to Medicare. You are encouraged to ask questions today throughout the webinar using the question box. Our team is standing by to respond, and Dr. Mingle will also pause throughout and definitely leave some time at the end to answer any questions that have been received. The webinar will be recorded, and the slides and recording will be distributed later this week by email. That should do it for logistics, and now I turn you over to Dr. Dan Mingle.
There I am. Good afternoon. I am Dr. Dan Mingle. Welcome to our webinar today. Let me advance a little bit here. There we go. We're again diving into the proposed rule. I apologize if this is getting a little repetitive for some of you. Our last week was supposed to be our last session on this, but we had some platform malfunctions and a lot of you weren't able to get in. So we added this additional session to introduce you to the proposed rule. So thanks for your patience. Sorry if you were caught up in that malfunction last week. So remembering this is a proposed rule, so there's nothing final about it. It is proposed for the program year 2018. So whatever parts of this or modifications of this are finalized, that final rule will be published. It's supposed to come out November 1st. Everything's been a little late this year with the new administration, so I wouldn't necessarily expect it before mid or even worst case scenario end of November. And of course, it will go into effect January 1st. Although some of the proposals in the rule correct some holes in the rule for 2017, so they'll actually pertain to the 2017 year. It was published June the 30th. We are past the comment date for which ended Monday night. So unfortunately, you can't make comments that will affect the final rulemaking, although there'll be other opportunities to comment for to help us go into the 2019 proposed rule and then final rule. So we'll talk a little bit about the adjustment model that's proposed, how that's proposed to change from 2017 to 18. We'll go review the performance categories and the changes proposed for those, eligibility and special populations, exemptions, exclusions, and make some final comments and be open for questions. And as Charles said, don't hesitate to ask questions throughout. My staff will be answering what might be individual to you, and anything of interest to everyone they'll pass on to me to answer to the group. So the characteristics of the transition year, starting there. In 2017, it was called the year of transition and iterative learning by Medicare. It was a plus or minus 4% year. They stated in the final rule it could last for 2 years. They presented some pick your pace options. They weighted cost at 0 points and quality at 60, and they set thresholds of performance at 3 and exceptional performance bonus at 70. I'll show you that graphically in a moment. And then they added a $500 million pool for the exceptional performance bonus. 2018, the proposed rule, it will definitely change to a plus or minus 5%. That's set by legislation. So there's no option there. Although the dynamics of the revenue neutrality to CMS means that it will soften the upside. There's not nearly a 5% gain on the upside as there has not been in 2017. That you couldn't gain as much as 4% in 2017. They are proposing to continue the transition modified for a second year, softening the transitions. There's still some pick your pace options. Cost continues. They propose to continue to weight costs at 0 points and quality at 60 points. So you get no downside or upside for your cost performance. Thresholds, they propose to change that performance threshold to 15. I'll show you that graphically in a moment, and keep the exceptional performance bonus kicking in at 70 points, again with a $500 million pool to add to that. Now, let's see, there we go. So here, this is the long-term conceptual model of MIPS, and shows how we have a composite performance score from 0 to 100 that combines all of the performance categories in a continuous variable that relates to the adjustment factor, which theoretically in the 2018 year will be a plus or minus 5%, with that exceptional performance bonus kicking in as this dotted line over here. The performance threshold is that number where this line crosses the 0 line. And long term, we expect that threshold to be at 60, but it was 3 in the 2017 year, and it is proposed to be 15 in the 2018 year. And that's and of course here's the schedule of the 4 payment or performance categories: quality, cost, advancing care information, and improvement activities. There's no proposed changes to the advancing care information, which is the new meaningful use, or improvement activities for these years. The 60-0 split for quality and cost is proposed to continue into 2018. Of course, that affects the 2020 payment year. We are now in the 2017 performance year. We will finish those submissions for you in 2018, and it'll affect your 2019 payment year. So we'll just advance one more set of years for that. Now, in the 2019 year, by legislation, the quality and cost has to be at 30 and 30. So we will be moving to 30-30 in the 2019 year. There are some exceptions and exclusions, so that it will be adjusted for some special circumstances, but overall, this is the expectation. And of course, the schedule, this adjustment factor is also set in concrete by legislation. It moves from plus or minus 5 to 7, then to 9. And of course, this $500 million exceptional performance bonus, which clicks in here, that's set at $500 million for these 5 years, for each of these 5 years, and then disappears after that. Of course, around this frame, somewhere around 2023, 2024, we expect a brand new legislation to be announced. Something will be replacing MIPS. Let's see, what's the acronym for? I have no idea what, except that we can pretty much count on it having the components of cost and quality. That is an enduring goal of health policymakers from both sides of the aisle, so we can expect it to continue. So here was the graph for 2017 and the transition year, with that performance threshold here, the high performance threshold here. So as long as you earn 3 points or more, as long as you will earn 3 points or more, so we're still in that year, you will lose nothing. If you don't earn those 3 points, you fall into this pit of despair, which is the full 4% loss. And in 2018, that moves out here a little bit. You need 15 points to avoid the loss. There's a curve that you don't lose everything right away, but then when you hit that that threshold of 3.75, then you fall into the pit and lose all 5%. So as long as you earn at least 15 points, now that's 15 points is all the points in practice improvement activities. So if you're in a perfect score in practice improvement activities, which isn't difficult, you avoid the penalty. If you get a quarter of your points for quality, you avoid the penalty. If you get, what is it, 60% of your points for advancing care information, you avoid the penalty. And anything above that slides you up the incentive range, and even it is achievable for most of you to get to 70 to share in the exceptional performance bonus. Now the scaling factor is the multiplier that changes this curve from plus or minus 5 to something lesser. And because it's so easy to avoid the pit of despair, Medicare predicts that the scaling factor is going to be something around 0.2. So instead of earning as much as 5% bonus, the top is going to be somewhere around 1%. And of course, that's not going to be known until all the numbers you're in and they do the calculations. And throwing in the exceptional performance bonus, they predict that the top earners will get to around a 3%. 1% plus another 2 with the exceptional performance bonus at the peak. The reporting period's adjusted a little bit for the proposed adjusted a little bit for the year. 2017, you could get away with a 90-day reporting period. They propose a full 365 days in 2018 and beyond. They propose to keep the advancing care information improvement activities, at least for this coming year, at 90 days minimum, up to 365 days. And it looks like that's going to go out into the future, but of course that's pending the final rule for 2019. We won't know for sure. They're encouraging voluntary participation, so even if you aren't required or eligible for a positive or negative adjustment in the MIPS program, they encourage all Medicare providers to provide data. You won't get a payment adjustment either positive or negative, no matter what your performance, if you're voluntarily participating. They want you to submit all available MIPS data, so they want to encourage us to submit more than 6 measures. Only the best 6 are going to be scored. They are proposing to support multiple and redundant submissions, and this is very new. This is interesting. I'm not sure it might not be more risky and confusing than it is helpful. I can see some areas where it might be helpful. So what they're saying is, in the past, you had to get a complete submission in through one mechanism. It was qualified registry or claims or EHR or QCDR, but one of those submissions had to be complete, and that was judged in its completeness and you couldn't break out and add measures from other mechanisms. Now they're proposing you can submit 2 measures through EHR and 2 measures through qualified registry, another 2 through claims, and get credit for those 6 measures. In reality, they'll first eliminate duplicate measures. So if you're submitting measure 2, or measure 2 isn't there anymore, measure 1, the hemoglobin A1C measure through multiple mechanisms, they're going to look at the best and only keep the best. And then they'll look for 6 unique measures amongst and give you the best of what's been submitted. I recommend that just to make sure there are no mistakes, you make 1 complete submission through 1 mechanism. If you want to supplement by others, go knock yourself out. That's it can only help, it can't hurt, except for the effort to do it. And that's basically the story there. Now, talking about the quality performance category specifically, they're still in all payer. So 2017, we're expected to give all payer data unless you're doing claims or web interface reporting. Those are Medicare only. They're still requiring a 50% reporting rate and proposing that for 2018. They've proposed to go to a 60% reporting rate in 2019, but that again is going to be subject to the rulemaking for 2019. They're expecting to get to 90% requirement by 2021, but again, that we'll see what comes in the rules. Incomplete measures will earn 1 point. An incomplete measure is that one that doesn't have a 50% reporting rate. You might have you might have 100 diabetics in your practice and only report the hemoglobin A1C on one of them, and that is an incomplete measure and will earn 1 point in 2018. It earned 3 points in 2017. Complete measures have a 3-point floor, so no matter how poorly you perform, as long as you have a non-zero performance rate and you have 50% reporting rate, you'll have at least 3 points for each of those measures. And then again, we're expecting a 12-month requirement for data with ACI and IA staying, that's advancing care information and improvement activities, each staying at a minimum of 90-day. So one of the concepts they introduced, CMS introduced in 2017, was this concept of measure stratification. So they're describing measures as class 1, class 2, and this year they're adding class 3. Class 1 is a complete measure. That is, it hits that reporting threshold, which is 50% of your eligible patients. It has a benchmark and it has a non-zero performance rate, and you can earn up to the top 10 points if you're a top performer in the nation. And of course, this is graded on a curve, so it's in comparison to your peers. It's not a gross score. Class 2 it's complete, but you have less than 20 cases that you're reporting. So you have fewer than 40 eligible instances, and with a 50% reporting rate, you're reporting fewer than 20. Or there's no benchmark. There haven't been enough practices report this measure for CMS to establish a benchmark to compare. And in all those cases, you get only 3 points for the measure. And then the class 3 is an incomplete data. That is lower than your 50%, so they're still going to give you points for that, and there's only 1 point, unless you're a small practice. And if you're a small practice, and I believe that, now they're varying their definition of small practice by context. I'm not remembering exactly which definition this is, but it's going to be set in the final rule, and it's not really set, it's now only proposed. But a small practice will earn 3 points for that incomplete data set for class 3 measure. Topped-out measures, they still don't like topped-out measures. They still want to get rid of topped-out measures. They still reluctantly hold on to them because particularly a lot of our specialty practices don't have enough measure choice to move away from those topped-out measures. So, but they are proposing a little bit more discipline to deal with them. They tell us in the proposed rule that 70% of claims measures are topped out, 10% of EHR measures are topped out, and 45% of registry and QCDR measures are topped out. And they're proposing a 3-year timeline to identify them. So topped-out measure, just for those who haven't been introduced to this before, topped-out measure is a measure where nearly everybody gets a perfect score. Or high score. So, and when you divide scores by deciles, as they're doing, you find you've got a cluster of top deciles getting that are getting the same score. So they're suggesting in year 1 they identify the topped-out measure. So that's year 1 is relative to the measure and their identification of it as topped out. In year 2, they apply special scoring, which they had initially proposed to be kind of a midpoint between the decile where it starts to top out and the top decile. So if the top 50% all get a perfect score, your best score will be 7.5 instead of 10 you can get for the measure. And then in year 3, they consider through rulemaking to remove. So they'll propose a rule, and in that proposed rule, they'll say we propose to get rid of measures X, Y, and Z because they're topped out. They'll collect your comments on that, and unless there's a lot of pushback, they will remove it. And so, of course, your methodology to keep it in place is to comment. All right, so let's move on to bonus. They've expanded and clarified some of the bonus categories, and in the quality category, they clarify that Measures that don't contribute to the score. So if they're only requiring 6 measures, they're only going to score 6 measures. If you submit 9 measures or 12 measures, those extra measures can get bonus points. Although the measures themselves, the scoring won't add to your composite score, but the bonus points can. Um, and those bonus points aren't considered in the overall improvement bonus calculation. They are introducing an improvement bonus. So if you're improving your quality score, you'll get bonus points for that. So the quality improvement score, I had initially thought when they introduced this, they'd take it measure by measure. So for any particular measure that you're able to improve from year to year, you get bonus points for that. But what they proposed instead is to take your total quality performance category score, and if that improves, to give you bonus for that. And here's the proposed math around that. So obviously, the better you do to begin, the better your baseline is, the less you have opportunity to earn that improvement bonus score. And it also is adding to the quality performance category, which pushes us all toward the top. And again, I think it takes away from some of the differentiation they're expecting to see in cost and quality by being able to compare us one to another. But anyway, this is what's proposed for 2018 with that improvement bonus capped at 10. Then, of course, there's still an electronic flow bonus, although they clarify this year that their intent was to have this available only for the first 2 years, which is interesting. And I think might bear some comment for the 2019 year to see if we can't hold that on. I still think there's some value to that, and perhaps they should move the bonus for that into the improvement activities category instead of the quality category. And you can still, I see a lot of misinformation out there about the electronic flow bonus. It's available this year in the 2017 reporting year. They propose to continue it into 2018. Whether it goes beyond there is going to be subject to rulemaking and your comments. But there's a lot of misinformation. Electronic medical record companies particularly are fond of saying that you can only get it through them, but that's not true. Any method where you can have an electronic exchange of data with your vendor that goes on to Medicare is eligible. So it can work for EHR measures, for DSV measures, for qualified registry measures, for QCDR measures, for web interface measures. It can't be used for claims, but everything else is valid if you fall into those rules that it is in fact all electronic and there's no manual entry involved. Then into the cost performance category, again, it remains weighted at 0 for 2018. It has to go to 30% for 2019. And they're still proposing to have a total per capita cost for all attributed beneficiaries, Medicare, which that's been around since the beginning of quality tiering. Medicare spending per beneficiary, which is inpatient charges, so each hospitalization costs on the average such and such. So that continues. Episodes of care continues, although it's being massively rewritten by the Republicans now. So I'm not sure where that's going, but everything that they said, that the 10 that were going to come live aren't. There's new ones. So and nothing obviously is going to come live in 2018. So it won't be till 2019. So it's still a mystery to me exactly how they're going to handle those episodes of care in the 2019 year. Advancing care information, again, that's the new meaningful use. They postponed the requirement to get on 2000, or they're proposing to, and I can't imagine how this would be backfilled because it's coming out so late in the year. You're not going to be able to rescope this, so I'm pretty confident that this will come through in the final rule, that they'll postpone that requirement to go to 2015 cert um, uh, until the 2019 year. So you've got an extra year to get those upgrades. They are being more specific about the exclusions for advancing care information, lacking internet connectivity, extreme or uncontrollable circumstances. They're all pretty much old and familiar to us. Don't have face-to-face interactions with patients, hospital-based clinicians who don't have control over who they think don't have control over CHRT, and they may not, but again, I'm not sure that everyone in ambulatory practice has control over that either. Added an ambulatory surgical center exception, and also gave us a little bit of break if our EHR is decertified. Gives us a little time. We have to apply for that exclusion, but it gives us a little time to either see that our EHR becomes recertified or switch to one that is certified. And again, for another year, NPs, PAs, CRNAs, and CNS who didn't need to do it under meaningful use still get a break into the 2018 year. If you apply and get granted the exclusion, ACI is weighted to 0. If you make a submission despite your eligibility for exclusion, you're going to be scored and it's going to be weighted as if there's no exclusion. So it really, you rule that by your submission. Group submissions, if you submit as a practice rather than as individuals, it requires inclusion of the ACI. And they've been more specific about the exclusions for e-prescribing and HIE, give us a clear mechanism to make sure that you don't get dinged if you don't e-prescribe medications or you don't have any opportunities for transition of care for the HIE measure. And basically, if you write fewer than 100 prescriptions annually, you don't need to prove that you have an e-prescribing solution. If you have fewer than 100 patients that move from you to someone else or from someone else to you, then you don't need to show the HIE functionality. Practice improvement categories, there's obviously a number of new practice improvement activities. I'm not going to get into that detail, but our staff will be prepared to help you guide you through those selections. Patient-centered medical home, there's just a little more clarification to that. That's been site by site that you get certified, not by tax ID number, and now they're saying as long as 50% of your practice sites, 50% or more are certified, then the whole group gets a patient-centered medical home points or credits. And they're continuing from 2017, that same half as many points are needed if you're not a face-to-face clinician, if you're a small practice defined in this case as 15 or fewer providers, or if you're in a rural or health personnel shortage area. And they're adding a couple bonus points that are being added directly to the composite score without going directly through the performance category. One, a small practice bonus. What they've observed is that for the final year of PQRS, 92% of the clinicians who are eligible for MIPS, who are now eligible for MIPS, 92% of them were participating in that final year of PQRS. So they're showing the ability and the willingness to deliver data about quality. But then when they look specifically at small practices, only 69.7% of those were participating in that final year PQRS. So obviously there's some kind of a problem in the small practices, and they propose to make up for that by just giving a flat 5-point bonus to make it a little easier for those practices with 15 or fewer clinicians. And then they'll annually reassess whether or not they need to continue doing that. So there's well, again, this isn't finalized in the rules yet, and then if it is, they'll still look at it every year. There's no expectation necessarily it'll continue year by year. I do expect a complex patient bonus. I expect this will come through because they do want to address complexity. They want to encourage us to take care of more complex patients, and I would expect this to be repeated year to year. But again, we'll wait and see if it comes out. So again, based on the HCC scores, many of you may not be familiar with HCC risk scoring. It's been around for a long time, but only applied to Medicare Advantage plans, and it's a way of adjusting the payments for more expensive patients, and that's based on diagnosis codes or combinations of diagnosis codes that they know are more difficult, more expensive to take care of. And by adding up the risk scores from that HCC profile, what they find is the maximum risk score is somewhere around 2.75 or 3, so that they've proposed a cap that's within that reasonable or rational range. The risk score will be based on the prior year's performance or prior year's claims, and they'll attribute patients to your practice in an overlapping performance year that's from September 1st through August 30th, again, applying that risk scoring, and that risk score will just be applied as a bonus directly to your performance score. And although they are saying they're going to assess it annually, whether that's worth, whether they can intend to continue that. Eligible clinicians in 2018 doesn't change from 2017. It's still the same group of credentials. There were, under PQRS, there were about 1.5 million Medicare providers that were subject to PQRS. When we take out the excluded credentials, which is everything there you see on the right, and newly enrolled clinicians, it drops it down to 1.3 million, and they're proposing to increase the low volume exclusion. In 2017, low volume was 30,000 or less in annual allowable charges, or 100 or fewer unique Medicare patients. In 2018, they're proposing to make it 90,000 or less in allowable charges and 200 or fewer unique patients, and that will drop the total number of providers eligible for MIPS to 647. Now, that's a relative term, because that only applies if you're applying if you're submitting individually. If you're submitting as a group, they look at those numbers as a group. So the credentials actually, no, excuse me, the credentials don't come back in, but the low volume exclusion disappears if you're above that as a group. And submit as a group. Now, for the excluded clinicians in this group, if you're in an alternative payment mechanism, these are all eligible for the alternate payment mechanism dynamics, the preferred payment or the financial loss, and the advanced APM bonus of 5% if you earn that. And this is just to point out that that's big slice of the pie on the left is just to show that, yes, 475 providers come back into the mix as eligible for alternative, the advanced alternative payment models if they're qualified by volume. That's the QP. All right, so a couple notes on special populations and special treatment and formal review. Again, the low volume threshold proposed to be at 90 instead of 30,000 and at 200 instead of 100 patients. They're still proposing that 2-year low volume threshold determination period. If you are low volume for either of those 2 years, you'll be low volume for the reporting period. We've already had the first excuse me, we're just about to end the first measurement period for 2018. That'll end August 31st, and then we'll go into the second measurement period. So if for this year you are low volume for 2017 reporting, you will also be low volume for 2018. And with a higher threshold, you might even if you weren't low volume in this reporting period, you might be later. There's a small practice size determination period, which is a single 12-month period, not two, for the 2018 performance year. Again, it's at September 1st to August 31st. with a 30-day claims run out, which means they wait until 30 days until September 30th to get all your claims from that previous period. They don't consider any claims for that period that come in after September 30th. And this impacts your virtual group eligibility, gives you more points, 3 points for an incomplete data for a class 3 measure. Fewer improvement activities are required, only have as many improvement activities to get your full score, and to become eligible for that small practice bonus. And of course, half as many points in improvement activities. Oh, we already covered that. Excuse me, that's redundant. Virtual groups is introduced finally for 2018. I wouldn't jump right on it, but it does seem to have some value. It's particularly valuable if you're sharing an infrastructure. And I think I'm particularly looking to groups if you're working with a billing company that provides you with a practice management system, and preferably even an EMR. You're sharing configuration and potentially a workflows improvement process with your peers. If you're in one community, a number of you that are banded together to take care of in independent practices to take care of a particular population of patients, there may be an advantage to doing virtual group. Virtual group means that groups of 10 or fewer physicians form a get together to report together. And of course, if you're expecting poor performance levels, you'd like to group with someone who's got really good performance levels, but of course they won't want you in their group. So that's not going to work well. But again, if you're sharing the responsibility for a group of patients, it is entirely possible that if you don't have record of a flu shot on your patient, someone else in your group might. And that would improve everybody's performance. Multiply that by all the measures you do. Or if you're sharing, again, the same practice management system and or EMR, you can get some mileage out of that by reporting together. Another fascinating advantage of the virtual group, if you can, particularly if you're sharing patients in one community, if enough of you, if you have 25 doctors together, you are then eligible to use the web interface to report, and with a 248 patient set for each measure in the web interface, it becomes possible again to pull charts and abstract them and create a submission, even if you're not if you don't have an EMR or don't have access to the data in your EMRs. So I think that's one particularly fascinating spot for virtual groups, to be able to be eligible for web interface reporting. But it's going to be hard with the time frame they propose. It'll be very hard to get a virtual group together for the 2018 submission year. Better to kind of look ahead and think about it for 2019. And when we'll start to put together a virtual group support package as soon as we know what the final rule is saying about that and what you're going to need to do that. There's a non-patient facing determination period, again a 2 12-month determination periods with 30-day claims run out that look like that low volume determination period. And if you qualify for that, they just weight ACI to 0 and give the points typically to quality. They're proposing a facility-based measurement option. Hospitals in the value-based purchase, hospitals have a value-based purchasing measure set. And if they're participating in that value-based purchasing program for the hospitals, a facility-based provider, so if 75% or more of your charges are in place of service 21 or 23, you can choose to use the facility measures as your quality measures. So they will apply that, whatever the facility gets for their score will be applied personally to you as your quality score. That's basically it. Fairly simple. You have to elect during the submission period. You may not necessarily know that it's better than what you can submit yourself. We used to call it informal review under value-based the value-based modifier and PQRS. Now they're calling it a targeted review. You still have a 60-day period from the time they announce your scores. They finish processing the numbers, and we expect again that to be somewhere in August or September of each year. Once those numbers are available and you know how you're scoring, you get 60 days to submit a request for a targeted review. And if there are extreme and uncontrollable circumstances, particularly around ACI, but the wording suggests that it might apply to other things, not just advanced care information, you can request a reweighting assessment. Again, another flavor of that informal review. I'm asking to be reweighted. So all or some of MIPS can be forgiven or reweighted, applies to the virtual group if the majority of the tax ID numbers are affected by whatever happened. So the final comment, and then we'll go into questions. You know, value-based purchasing, I think you can count on to be here to stay. We can count on the new legislation sometime in the next 3 to 5 years, and that the new legislation will continue to include pieces of requirements for quality and cost measurement. Whether the advancing care information stays in or practice improvement activities stay in, those are just extra details, and I don't think are part of the core package or requirement. Performance now matters. PQRS was paid for reporting. MIPS is paid for performance. So you should be investing in measures that matter, not just something that you can measure easily. If you don't care about flu shots, you shouldn't be reporting on flu shots, because you shouldn't invest things in care that you don't intend to provide to your patients. Have extra measures in the hopper. So even if you've got a good 6 measures you're submitting this year, have at least 6 more under development. So if some of your measures top out or they get discontinued, that you have others to fall back on. And submit extra measures, because they can only help you. That doesn't look like they can hurt you. They'll help to flesh out the benchmarks, even if they're not scored, and that makes everyone's lives a little easier. Understand and improve the data value stream. So somewhere in that course, from providing the care to documenting the care to extracting the data to translating it to submitting it, anywhere in that value stream can be the malfunction of your measure. So get help to understand where that is, and continually work on making that better. And you're going to have to contain costs, even though it looks like we'll still get another year off from that cost measurement and from being paid differentially on the overall cost of care that we're delivering. It's not going to be forever, so you'll need to find ways to contain costs so you perform better there. And think about that cost value stream, which is partially patient-centeredness, accessibility, planned care, avoiding excess, making sure you're keeping it to avoiding excess of care, waste and delays, which increase the costs. And just a couple of things. We've seen the last of this graph. This graph has been produced annually in the PQRS system and shows the success rate of each of the mechanisms of submission to earn the incentive. When there's no longer a PQRS incentive to be earned, they dropped this graph, but it was the most clear that showed the relative value of each of these submission mechanisms. And I just point out the claims has always been dismal. If you've got a good claim submission technique and it's been working for you reliably, stick with it, although Medicare still says they're going to discontinue that. They haven't told us when. Um, but don't expect performance out of your claim system. They fail 60% of the time. And of course, we're not going to see clean data like this in the future because we no longer have that incentive. And it's now in that it's no longer in the pass-fail system. It's in the continuous. It's a continuous relationship, so it's not going to be as easy to see. EHR measures fail 43% of the time. QCDR fails 57% of the time. Now, I think, well, a lot of the EHR deficit is because, it's hard. An EHR takes about 2 years to put good new ideas into their code and another 2 years to get out to their clients. It's really difficult for them to rise to the quality reporting challenge because the rules change more quickly than that. They change every year, and they change only 2 months before they're to go into effect. So I still think the most reliable methods are the web interface method and the qualified registry method of reporting. And the GPro still is the most cost-effective, the group practice reporting option. So lean toward those and don't expect as good guidance as this in the future as to what's passing or failing. And this final, this bowl of spaghetti is kind of a tracking over the years of participation in PQRS and kind of a look ahead. The dotted lines are as we look at in the MIPS what we expect to happen. So we've seen participation rates or the non-participation rate drop. So participation rates go up, particularly since it became a penalty-based system starting in 2012. It really caused a pickup in participation. Claims was always the most commonly used method, even though it fails so frequently. Overtaken by qualified registry in the 2014 year, and since then it's been exceeding claims, and it is the best method, so it's right that it should be there. We expect that to continue to improve, although with the numbers of eligible clinicians dropping, we see everything drop in this 2017 year. Except ACO APM, the alternative payment models rely on the web interface, and that's this, so we expect that actually to increase as that's still the predominant way for ACOs and alternative payment models to submit, with the exclusion of the Comprehensive Primary Care Initiative, which uses modification of the EHR method to submit. And the utilization of EHR and QCDR have been just lagging way behind, and with their failure rates, they deserve to be way behind. And of course, we're seeing more excluded clinicians, which is reflected up here. And that's basically that. That's the end of my comments. We got 12 minutes left in the hour or something like that. Oh, I've got a question from Jenny, and I'll preferentially answer those live questions that you send me, but we also have some that people pre-submitted I'll get to while we're waiting for others to come in. Jenny asks, are the positive or negative adjustments on EM charges only or on all charges? Just Medicare patients? Good question, Jenny. The adjustment is to all Medicare Part B charges, and only Medicare Part B. Even though we're reporting on all payers, it only applies to Medicare Part B, and not just to the E&M charges. So let's see. Let's go to Raymond asks, back to Raymond. Do low volume providers have to participate in 2018 MIPS? And the answer is no. As long as your low volume falls into that under 90,000 allowable charges or under 200 patients, if that in fact is what's finalized in the final rule. Now again, that's as an individual. If you're submitting as a group, your volume is going to be judged as a group. So as a group, your allowable charges could still be under 90,000, or your patients under 200. In either case, you don't have to submit. But if the group analysis brings it up, then you will have to submit. Now, so there's a little strategy around that. If you expect to earn an incentive, obviously you should submit as a group. If you expect to get a negative adjustment, then you might then not submit as a group and therefore exclude as low volume providers. Carrie asks, can the practice evaluate individual versus group reporting? Can the practice about individual versus group reporting options using your solutions? And the answer is yes. We'll be running both sets of metrics on all data that we receive, and you'll be able to see those as you select and finalize your submission. All right, still nothing fresh from the studio audience. So on to Carol Ann. Carol Ann asks, can you explain the hardship exemption for the EHR incentive program negative adjustment for 2018? Yes, interesting. Thanks, Carol, for bringing this up. It's a good catch. There is an interesting twist in the rule that allows you in the meaningful use program, to avoid the final negative adjustment, which will be levied in 2018. So let's just go to that CMS page. So if you go to your to the slide deck and to this question, you'll see the link, and that'll take you to the to this CMS web page. And this is a live look at the web page. And down here they have the hardship instructions and the hardship application. And basically what they're saying is, if you're a first-time participant in the EHR incentive program in 2017, and I believe that means, from my reading of the rule, if you didn't earn the incentive in the past, even if you made a submission that failed, you could be considered a first-time participant. If you're transitioning into MIPS for 2017, you intend to report on the advancing care information category in 2017. Now, that doesn't necessarily say that you do report. It says that you intend to. So if you match all those things, you can apply for an exemption and not get levied. I think it's a 3% negative adjustment if you weren't a meaningful user in 2016. That is the year that's already passed. You can't make any submissions for it anymore, but you can avoid the penalty if you put in this application. It's a fairly easy application. You identify yourself and your company and your tax ID number somewhere. Well, it's got to be here somewhere. And you identify the individual tax ID numbers or NPIs, the individual providers who are affected, and you can attach other lists to this. You can attach an Excel spreadsheet that provides that or something like that. But it's a very simple application. That's all there is to it. And then and it says that it attests that to those statements of eligibility. And then they tell you whether it's applicable to you or not. So can't hurt, and it looks like it's pretty easy to send in. So again, if you haven't been a meaningful user in the past, and you're subject to a penalty for the final year that ended the 2016 meaningful use performance year, you can apply for this exemption to get out of that negative adjustment for 2018. All right, that's all there's there. Mary asks, how will specialists be impacted different from a PCP? Mary is a podiatrist. And basically the rate, the adjustment rates are the same. and they apply to your total allowable charges. Um, uh, so the two things that are different, of course, is specialty by specialty, our expected um, uh, revenue or allowable charges tends to differ. The Medicare volume differs from place to place and specialty to specialty. And of course, the measures applicable to you are extremely different. That's the biggest difference from specialty to PCP. PCPs tend to have an abundance of measures they can choose from, whereas specialists often have difficulty finding enough that are measurable. There may be 6 or more measures for you, but to easily access the data can be a big challenge, especially in EMRs. EMRs are not yet optimized for quality reporting. It can be very difficult. Bassman asks, can you talk about mental health services, specifically clinical psychologists and clinical social workers? Well, the good news, Bassman, about mental health services, and particularly these 2 specialties, is they're not required to do MIPS. They are if you're part of a group that's doing an alternative payment model. Depending on how that alternative payment model is constructed, you may or may not be part of that. And you are eligible for that, but you are excluded from MIPS for 1 more year. And whether or not it's up to the Secretary of Health and Human Services whether these particular specialties and the others that are excluded in the first 2 years of MIPS, it's up to the Secretary whether they're brought back in for the 2019 year or a year subsequent to that. So we'll wait and see what happens in next year's proposed and then final rule. Oh, the other thing about mental health services there are very few. It's hard to find enough measures in mental health services, and particularly things that are measurable. Some of the measures are just too complex and too many moving parts to really be convenient and simple to do. I think there's good opportunity in mental health services in a QCDR or in measure development to be proposing new measures and bringing new measures to the market. Sandy asks, can you dig deeper? And we covered facility-based measures, I think, well enough. If someone has specific questions, please enter them, but I don't think I'll go there. Rose asks, I've read that CMS is proposing to have a 90-day reporting period for testing to meaningful use. We answered that as well in the meat of the presentation today. Jared asks, do we know what date the proposed rule will be adopted or not? Well, by law, it's supposed to be November 1st, but I know that they were late with the proposed rule. So I think there's a clock. There's a mandatory time between when they closed for comments and they can incorporate the comments. And I think they're already late based on that timeline. But you know, at the earliest, I expect it November 1st. At the latest, I expect it November 30th. So look for it sometime in November. Patty asks, how does this impact the notice of proposed rulemaking? Do they think, you know, I don't think that's, the QPP NPRM is what we just discussed. MIPS and QPP are really not quite synonymous, but this was the quality, quality payment program proposed rule, which covers MIPS and APMs. We talked, I think it gave you everything I had about virtual groups at the moment. I guess there's some more details, but I think it's out of the scope of this this discussion. And I think I can't provide a lot more clarity until those rules are finalized. Again, the important things of that is it's applicable to just small groups of 10 or fewer. You can band together, you know, as large a virtual group as you want, as long as each of the component, the tax ID numbers has 10 or fewer providers, and you can, and you're responsible for one set of measures across all performance categories. And there does have to be an agreement. Apparently, when you choose to be in one, you can't break it up in the first year. It's going to be together for that year. You can choose not to go into another year with it. That's about it. Lindsay asks if none of the physicians in the group, well, I'm going to pause there because I just hit the 1 o'clock hour. I see 1 o'clock in the bewitching hour here. And frankly, these are, we're into pre-submitted questions, so nothing fresh. I'll pause in case there's any other fresh questions coming through, but it's time to get back to work. Thank you very much for your attentiveness, for the good questions. No one threw anything, so I consider it a rousing success. And do join us again for future webinars. I look forward to reporting good news when this rule is finalized, and we'll continue to tell you how to succeed in MIPS 2017. That will be our next webinar next week. Thank you. Oh, Luke has a question. If most of the providers are reporting the 90 days, why the exclusions in ACI are annual based? You know, there's Luke, there's an interesting push and pull between the 90-day reporting period and some of the reporting specifications that are year-long, and some of the exclusions which are year-long. So, you know, I don't know what to tell you about that, except it is what it is. And I think it's really not that difficult to deal with an exclusion that covers an annual measure versus a report that covers just 90 days. I can easily, based on data I received from you, could easily report that you had fewer than 100 prescribing opportunities in the year, and then you had more than 100 in the year, and this is the number that you delivered in this 90-day window. That's perfectly consistent with a good measurement and reporting system. But again, it does. Medicare's, we're dealing with Medicare, and their motto is we're big enough to not have to worry about about it making sense. All right, well, seeing no other questions coming through, I'm asking my staff. Nothing else coming through? Thank you again very much. It's a lovely day here. I hope it's as beautiful wherever you are. And again, I look forward to seeing you in future webinars. Thanks a lot. Ta-ta for now.